So today we are looking at bleeding in early pregnancy. Bleeding that occurs in early pregnancy. Now, one of the most common complications of bleeding in early pregnancy include one of the common complications of early pregnancy is bleeding. And usually, when one is bleeding in early pregnancy, when we say early pregnancy, usually we are referring to the first trimester. So, in the first trimester, that is the first 12 weeks of pregnancy, when a woman presents with bleeding to the hospital, you should think of these 4 differentials. Ectopic pregnancy, it could be abortions, it could be molar pregnancy, it could also just be implantational bleeding. So now, in looking at these common differentials for bleeding in early pregnancy, we are going to start off by looking at ectopic pregnancy. Now, what is ectopic pregnancy? Ectopic pregnancy is simply a type of pregnancy where implantation occurs outside the uterus endometrium. So the endometrium of the uterus. When a pregnancy occurs outside the uterus, the endometrium of the uterus, then it is ectopic. So it therefore means that it can either be uterine or extrauterine. That is how we classify sites of implantation. Sites of implantation can either be uterine or extrauterine. So uterine meaning it can be in the cervix, just below there, the uterine endometrium. So it can be cervical, it can be angular, it can be corneal, it can also be cesarean scar. If this woman has had a previous Caesar, meaning implantation may occur at the site of the scar. Then extrauterine, you can have tubal, which is the most common site, ovarian, and then abdominal. Abdominal can be primary or secondary. Secondary meaning it can either be intraperitoneal and extraperitoneal. Extraperitoneal meaning it occurs in the broad ligament. Now, tubal is the most common site. Why? Because we know that fertilization occurs in the ampulla of the fallopian tube. So that is why the chances are increased there that ectopic pregnancy will occur there in the tubes. Now, which sites in the tubes? It can occur in the ampulla, which is the most common site. Then it can also occur in the isthmus, the infundibulum, and the interstitial. So these are the different sites of what implantation of the fetus or the fertilized egg in forming an ectopic pregnancy. Now, what's the epidemiological data? So the most common site of implantation has been mentioned is what? The ampulla of the fallopian tube. That is the most common site. According to data from the WHO, from the World Health Organization, the general population has an estimated rate of about 1 to 2% of ectopic pregnancy, and about 2 to 5% of those who have used what? Assisted reproductive technology. Assisted reproductive technology, according to WHO. Now, the cause is actually not well established. However, there are risk factors, predisposing factors that increases the chance of one having or developing ectopic pregnancy. History of PID, pelvic inflammatory diseases, because these diseases may affect the fallopian tubes, may affect the uterus, damaging the integrity of the lining of the fallopian tube as well as the uterus. And when successfully treated, the damage may heal by fibrosis, decreasing the propulsion of the rate of propulsion of the fertilized egg from the tubes into the uterus. Hence, because of this reduction in propulsive forces, the fertilized egg may just lodge within the tube and implant there. So history of PID is a risk factor. History of tubal ligation is a risk factor. History of contraception failure is a risk factor. Previous ectopic pregnancy is a risk factor. Tubal reconstructive surgery is a risk factor for developing ectopic pregnancy. Then history of infertility. Then assisted reproductive technology, particularly if the tubes are patent but damaged, is also another risk factor. IUD use is another risk factor. Previous induced abortions is also another risk factor. Tubal endometriosis is a risk factor. So these are some of the most common risk factors for developing ectopic pregnancy. And what are some of the clinical features? So the patient may come in complaining of abdominal pain. They may complain of amenorrhea. Amenorrhea meaning a history of not having menses. They may complain of vaginal bleeding. Most cases it is spotty. Then there's also shoulder tip pain. Why? Because due to fluid buildup, it begins to irritate, especially if it is a ruptured type. Due to the rupture, it irritates the internal structures. These internal structures, because of the shared common nerve roots, there's referred pain from the abdominal area to the shoulder tip. That is why you may have shoulder tip pain because of shared irritation of the nerves, common nerves. So the patient may complain of having a shoulder tip pain. Then signs of shock if ruptured. Now what are the signs of shock? A weak and thready pulse, cold extremities, and hypotension. So these may be present. If you see these, then you see that the patient is in shock. Yeah. Now, on examination, the abdomen may feel tense and tender. It may feel tense and tender, and then pelvic examination is less informative due to extreme tenderness and should be performed by an experienced consultant, obstetrician, to avoid the precipitating intraperitoneal hemorrhage. That is the pelvic examination. Please, pelvic examination should be performed by an experienced obstetrician, usually a consultant, to avoid the precipitating intraperitoneal hemorrhage. Then there's also the vagina, the mucosa of the vagina may look blanched white. Then the uterus seems normal in size or slightly bulky. It may just look normal, slightly bulky. Then extreme tenderness on fornix palpation or on movement of the cervix. There may be tenderness. No mass is usually felt through the fornix. Then the uterus floats as if it is in water. That is another examination of finding. Now, what are some of the investigations? Some of the investigations you may need to do include labs. Now, for labs, you may want to do full blood count, differential count. Also, this one may help you to, especially if there is shock, you may want to know how much blood has been lost in terms of the red cell count as well as the HB count. You want to check for that. Then kudocentesis. Kudocentesis is simply the aspiration of fluid in the pouch of Douglas. Fluid in the pouch of Douglas. That is kudocentesis. Yeah. Then you also want to do beta HCG estimation. beta HCG estimation, you know that in a normal pregnancy, beta HCG doubles every 2 days. It doubles every 2 days. But then if you start seeing that as you do the beta HCG or beta HCGs, it begins to go down, then you know that it begins to reduce. Then you know that something is wrong, and it actually helps you in making the diagnosis of what ectopic pregnancy. Then you also want to do serum progesterone, because in the early stages of pregnancy you want it to be high. Why? Because progesterone helps in sustaining the corpus luteum until up to between 8 to 10 weeks, where there's a luteal shift there. Yeah, so you also want to check for progesterone. Yeah. Then imaging, you may also want to do a transvaginal ultrasound, and other invasive procedures may include the laparoscopy, which is the gold standard as it offers both diagnostic and therapeutic advantages. So laparoscopy is the gold standard for what? Both diagnosis and treatment. Then you can also do a dilatation and curettage, and in extreme cases you can also do laparotomy. Now, how do you manage ectopic pregnancy? So there are various treatment options, which may be: 1, you can do expectant management; 2, you can do medical management; 3, you can do surgical management; or 4, ablative, based on because this is a case-by-case situation. So there's no rule of thumb to say every time a woman comes in, she has ectopic pregnancy, then you should just do surgery or just do expectant management. No, you evaluate, and then based on the case, the evaluation, you make a decision. Now, what is it that is under expectant management? So with expectant management, this is where we only observe. So observation is done and hoping spontaneous resolution. And what are some of the indications? When the initial HCG, beta HCG is less than 1000 international units per liter, and the subsequent levels are what? Falling. When they are falling, it means the pregnancy is not continuing, but it's probably the fetus is dying and regressing rather. So when the initial serum levels are what? Less than 1000 international units per liter, and the levels are what? Falling, then you can do expectant management. When the gestational sac is less than 4 centimeters, small, meaning you can do expectant management. And when there's no when there's no heartbeat on the transvaginal ultrasound and no evidence of bleeding or rupture on transvaginal ultrasound, then you can do expectant management. So these are some of the indications for expectant management. What about medical management? So the drugs that are commonly used for medical management or salpingocentesis include methotrexate. We have potassium chloride and prostaglandins. Yeah, then hyperosmolar glucose, actinomycin. So these are some of the drugs that are commonly used. And the indications for these drugs include the patient must be hemodynamically stable. Hemodynamically stable. The serum HCG levels should be less than 3000 international units per liter, not more than 3000 international units. And the tubal diameter should also be less than 4 centimeters without any fetal cardiac activity. Then you can do medical management, and there should be no intra-abdominal hemorrhage. Then for systemic therapy, a single dose of what? Methotrexate of about 50 milligrams is given intramuscularly. This one is for systemic therapy. So this is on medical management. Then you have to also monitor the levels of beta HCG on day 4 and day 7 as you begin your treatment. So now when the HCG is declining between day 4 and day 7, when the HCG is declining and this decline is greater than or equal to 15% of the initial HCG, then the patient is followed up weekly with serum HCG until HCG is less than 10 milli international units, less than 10 milli international units per mil. Now, if the decline is less than 15%, again, a second dose of methotrexate, 50 milligrams, is given on day 7. Then variable doses of methotrexate, which may include 1 milligram IM on day 1, 3, 5, and 7, and leucovorin 0.1 milligrams per kg IM on day 2, day 4, day 6, and day 8. And serum beta HCG is monitored weekly until less than 5 milli international units per mils. So this is how you adequately do your medical management of ectopic pregnancy. Then there are also different surgical options that are there. There is also what we call conservative surgery. So with conservative surgery, so the procedure can be done either laparoscopically or by a miracle surgical laparotomy, and the indications are cases not fulfilling the criteria for medical therapy and cases where beta HCG levels are not decreasing despite medical therapy. Then persistent fetal cardiac activity, you may want to do conservative surgery. Then you can also do a linear salpingostomy. So salpingostomy, this is where we have a longitudinal incision which is made on the antimesenteric border directly over the site of the ectopic pregnancy. Yeah. So that is the. So then there's also linear salpingotomy. So there's the salpingostomy and salpingotomy. Yeah, so here the procedures are the same as those of salpingostomy, but the incision line is closed in 2 layers. Okay, it's closed in 2 layers, though not commonly done. And there's also what we call segmental resection. There's also what we call segmental resection and also fimbrial expression. All these are options that are there. Yeah, so now for salpingectomy, so this one is done when a whole of the affected tube is damaged and the contralateral tube is normal. This is where you just make an incision on the fallopian tube and remove. In fact, this one involves excision of the fallopian tube on one end, or one fallopian tube on one side is damaged and the other one is not. So the damaged fallopian tube is just removed. Then also salpingectomy is done when future fertility is not desired. Yeah, so then following conservative surgery or medical treatment, the estimation of beta HCG should be done weekly till the value becomes less than 5. Then also additional monitoring by transvaginal ultrasound is also preferred. Yeah. So that marks the end of this presentation.